the chairmanship of Dr. Joshi sir. I welcome our chairperson Dr. Joshi sir, and yes sir, thank you sir. And I also welcome our uh, mm, our ex-EB member Dr. Kasi Bhandaru and Sushant, and I also welcome our Joseph sir, our national expert. Although I think Dr. Indu Madam is just joining, है ना? So we are waiting for her. But maybe, sir, I will proceed, sir. Right, sir?
Yeah.
I also welcome our session expert, Dr. Dheeraj Shah, sir. Sir is a well-known figure, and sir is at present working as a principal in University College of Medical Sciences, as well as sir worked as a editor-in-chief in Indian Pediatrics. We all know, sir, and even dean for of the ICP and director names and so many things. Sir has sent me the short biography, but if I read these all these, it will take half an hour. So sorry, sir. You are a well-known figure. Sir, please unmute, Dheeraj, sir. And I also welcome Dr. Rasmi Ranjan Das, our session is yeah, at this. He is a professor in the pediatrics in the AIMS Bhubaneswar, and he is session mentor. And I also welcome our presenter, Dr. Nisa Sahu. She is DM resident, pediatric pulmonology and intensive care in the AIMS Bhubaneswar. So with all these words, now I invite our presenter. So to start this, sir, Joshi sir, you may sir say something, sir, at the beginning.
No, I think it's. Thank you very much for inviting me, Dr. Ajay Kumar. I think it's a privilege to be a part of this. I have been, whenever possible, been a part of Journal Club throughout the last year also. However, since it used to clash my clinic timings, often used to join late. But they are very, very enlightening and thought-provoking sessions. And with experts like Dr. Joseph Matthews, sir, who is a stalwart in the field of analysis and journal writing and all things. So we get a lot of information from his insights also. So all in all, Dr. Indu is always there. So all in all, it's a very thought-provoking experience and very happy to part of this. So my best wishes to Dr. Ajay Kumar and my kind regards to Dr. Joseph Matthews sir. Good evening to Dr. Dheeraj Bhai. We just met at Pedicon. So this is very nice. And Dr. Dear Rashmi is there. So I think let's not waste further time. You can just start. Thank you so much.
Okay.
And before, just sorry to tell you,
Yes, sir. Yes, sir.
before kindly permit me to leave this session for some time because I have to go for the inaugural session of the advanced asthma course at
Yes.
9 p.m. also. So I'll
Yes, sir.
join back
Yes, sir.
here again.
Yes,
So
sir. Yes, sir.
thank you
Okay,
very
sir.
much.
Okay, sir.
Yeah, yeah.
Sir, Dr. Joseph, sir, ca can you take the charge, sir, in absence of Dr. Indu, madam?
Sure. We welcome Dr. Nisha Sahu, and you go ahead with your presentation. Thank you.
Thank you, sir. Am I audible, sir?
Yes, you are audible.
And screen is visible, sir?
Yes,
Yes.
if you will be able to make it full screen, it would be better.
Yes, sir. Yes. Okay, good evening, everyone. I'm Dr. Nisha, Dr. DM resident in pediatric pulmonology and intensive care from AIMS Bhubaneswar. Today we'll be Okay, today we'll be discussing a journal entitled Budesonide Formoterol versus Salbutamol as reliever therapy in children with mild asthma. It was a 52-week open-label multi-center superiority randomized control trial. It was published in Lancet in September 2025. And we know that ICS formoterol reliever monotherapy is the preferred treatment for mild asthma in adolescent and adults, though the terminology mild asthma is to be avoided as per GINA guideline as far as possible. This was the terminology used for infrequent asthma, infrequent symptoms when the study was conducted, and this statement was supported by previous RCTs, which included Sigma 1, which was Symbicort as given in mild asthma. Symbicort was a combination of budesonide and formoterol, and this was a study which was published in NEJM in 2018. And this was a 3-arm study which had compared SABA only as a reliever with ICS formoterol as reliever, and the third arm included budesonide maintenance with as needed SABA as reliever. And the participants included were above 12 years of age. They concluded that there was 60% reduction in asthma attacks in the ICS formoterol group when compared to SABA only reliever group. And another study was Novel Start. It was a similar study, but it was an open label study as compared to the Sigma one, which was a blinded study. This was also published in NEJM in 2019 and had similar 3-arm groups, but the age group was between 18 to 75 years. Also showed that there was 51% reduction in attacks in the ICS formoterol group compared to the SABA reliever group. In the subgroup analysis of Sigma 1, which was between in the age group between 12 to 17 years, it showed that there was 77% reduction in severe attacks with ICS formoterol when compared to SABA reliever group. So, but there was no RCTs which were specifically conducted in children below 12 years comparing ICS formoterol as reliever monotherapy compared to the SABA only reliever monotherapy. So these studies established a base for the changed guidelines in GINA for adults and adolescents using anti-inflammatory reliever therapy from step 1 itself. So why the study was chosen to be conducted, as asthma is a common chronic disease in children and which is associated with significant morbidity and mortality even in mild asthma, and many rely on SABA only therapy with poor compliance to the ICS based regimens, which increases the asthma exacerbations and hospitalization. So this study hypothesizes that as needed, budesonide formoterol reduces asthma attack rates, which was superior to as needed salbutamol in children aged 5 to 15 years. And the aim of the study was to compare the efficacy and safety of as needed budesonide formoterol versus salbutamol in children aged 5 to 15 years using SABA only treatment. This was the trial design. After screening, consent, and enrollment, at week 0, after randomization, the participants were enrolled divided into 2 groups, and first one intervention group received budesonide formoterol 50 microgram and 3 microgram for formoterol, 2 puffs as needed, and Salbutamol 100 microgram 2 puff as needed in the another group. There were total of 5 visits. First, three groups at week 0, 26 and 52 were physical visits, and two visits were at week 13 and 39 were telephonic visits, which included where multiple parameters were noted, which I'll be discussing subsequently. And week 0 was the completion follow-up. Coming to methodology, this was a multi-center open-level phase 3 two-sided superiority RCT was conducted across 15 community or hospital-based clinical trial units across New Zealand and conducted for 2021-2023. Trial was registered under Australian New Zealand Trial Registry, and ethical approval was by Northern Bee Health and Disability Ethics Committee. In the study, the inclusion criteria were children aged 5 to 15 years with parent or carer reported doctor diagnosed asthma who were currently using SAVA only inhaler, plus at least one of the following with SAVA use on 3 or more consecutive days in past 12 months, or SAVA use on 2 or more days per month on average in past 12 months, or any urgent medical review for worsening asthma in past 12 months. Exclusion criteria of the study were hospital admission for more than 24 hours for asthma in the last 12 months, self-reported use of more than 6 asthma inhalers in the last 12 months, any use of ICS, LABA, leukotriene receptor antagonist, theophylline, anticholinergic agent in the last 6 months, or any use of systemic steroids in the last 6 weeks, any medical condition which may impact study result, including cystic fibrosis or bronchiectasis, or any known or suspected contraindication to the medication in the study, any previous life-threatening asthma requiring ICU admission, or those unwilling to switch from current asthma regimen, or those unwilling to provide written informed consent. Basically, any severe asthma exacerbations were not in the past 12 months were not included. And the intervention group was as needed budesonide 2 puff and comparator was as needed salbutamol 2 puff. The primary outcome measured was asthma attack rate per participant per year, which included moderate or severe attacks. And the definition were based as per the ATS or ERS criteria. Moderate attack was defined as worsening asthma, which required urgent medical review with OPD or ED visit or hospital admission with no systemic steroid prescribed, and severe asthma as those with worsening asthma, which required urgent medical review or admission where systemic steroids were required. And worsening asthma was defined as having any respiratory illness with increasing wheezing or increasing reliever use as per the parents or doctor documented. These were the secondary outcomes which included severe asthma attack rate per participant per year, or at least one asthma attack, or those having at least one severe asthma attack, the proportion of participants on each treatment step, time to first asthma attack and first severe asthma attack, those the days in hospital due to asthma, FeNO and FEV1 measured on week 0 and week 52, ACQ-5 score measured documented on week 0, 26 and 52, days lost from school and work, and total systemic steroid dose, growth velocity, and adverse events, serious adverse events. About randomization, this was a stratified variable block randomization, which was with the allocation ratio of 1:1, and the stratification factors were among age group between 5 to 11 years and 12 to 15 years. Another was history of severe attack in past 12 months with either 0 or 1 or more severe attack. This was a computer-generated sequence. Allocation concealment was maintained by secure database, and this was an open level study. There was also special rule for those uh, of same household participants. If the first child was randomized, all others received the same treatment. Coming to sample size calculation, the initial sample size calculated was a total of 320 participants with 160 per group, which was designed to get a power of 90% and a two-sided alpha of 5%. This was to detect a relative rate of asthma attack of 0.55, and which was derived, which was taken from previous studies which showed reduction in asthma attack from 0.51 to 0.28 per participant per year in those using steroid inhaler as reliever therapy. And also, it was also powered to detect severe severe asthma, relative rate of severe asthma attack of 0.45, and again with previous studies, a reduction from 0.32 to 0.14 per participant per year. Attrition they had allowed was around 20%. So the planned sample size was 380 with 190 in each group. This was a statistical analysis. Like for analysis, they had used intention to treat superiority analysis. For primary outcome, which was asthma attack count, was analyzed using generalized linear mixed model. Sensitivity analysis for pre-specified variables was done using univariate adjustment for age group, sex, ethnicity, trial site, baseline, ECQ-5 score, history of severe attack, and time to event analysis was done with survival analysis for time to first asthma attack, time to first severe asthma attack. A Cox proportional hazard was used for the same. For continuous outcome, ANCOVA was used for FeNO and FeViver, which was adjusted for baseline values in household clustering, and for FeNO, the device was tested as confounder. I won't be going into detail about this because of time constraint. So, continuing with the study regarding the treatment algorithm, in the control group, reliever was used as reliever which was used was salbutamol, and the brand was Ventolin 100 micron 2 puff as needed for symptom relief. And in step 1, no regular treatment was given. In step 2, after one severe attack, a low dose ICS fluticasone was added with 1 to 2 puff BD, and 1 puff for those below 12 years and 2 puff for those above 12 years. After 2 severe attacks, they were escalated to step 3, where ICS LABA was prescribed, where fluticasone salbutamol combination was used with 1 to 2 puffs BD. And in the intervention group, which was anti-inflammatory reliever algorithm group, the reliever which was sorry, prescribed was Symbicort Rebihellar. The concentration being 50/3, and 2 puffs were used as needed for symptom relief. Step 1, again, nothing was, no regular treatment was given. In step 2, after one severe attack, Symbicort Rebihellar was given as maintenance, along with the reliever, same reliever whenever needed. And in step 3, after second attack, the dose was increased from 1 puff to 2 puff BD. And these were aligned with the New Zealand pediatric asthma guidelines. I'll be discussing in brief about the New Zealand child asthma guidelines, which they had mentioned. And also I'll compare this with latest GINA guideline. So as per the New Zealand guideline, in step 1, there was no maintenance therapy was started, and in step 2, maintenance therapy with low dose inhaled corticosteroid was has to be started. In step 3, maintenance low dose ICS LABA has to be started. And for reliever, SABA reliever is being used 1 to 2 puff, unless smart therapy is being given, as in step 4 or 5. And this was the treatment of children with asthma of 5 to 11 years. And coming to the latest SENA guideline in children aged 6 to 11 years, as compared to the New Zealand guideline, the only difference we can see here is in step 1, along with the reliever as needed SAVA, which was similar in the New Zealand guideline, whenever SAVA is taken, low dose ICS is taken, and this corroborates with the anti-inflammatory reliever therapy. And in step 2 and 3 are similar. It's just the reliever, whenever SAVA is taken, reliever has to be whenever SAVA is taken as a reliever, low dose ICS has to be taken. And the GINA 2025 guideline for adults and adolescents includes anti-inflammatory reliever only therapy in step 1 and 2 itself, with similar treatment in step 3, 4, and 5. So GINA has already introduced this anti-inflammatory reliever therapy concept in children above 12 years of age. But there were no studies below 12 years of age prescribing anti-inflammatory reliever therapy at that time point. So they had conducted this study. So coming to results, this is the concert flow showing that 382 participants were assessed for eligibility, and out of which 22 were ineligible, and so 360 were enrolled, and 342 were randomly assigned, 18 were allocated. This allocated group was probably those who were from the same family, that after the first child is randomly assigned, others were allocated in the same group. They were 171 were randomly assigned to salbutamol group, and 171 to the intervention group. 10 were allocated, and 10 were allocated in the salbutamol, 8 were allocated in the intervention group. Finally, 162 in each group underwent treatment, and 181 were analyzed by intention to treat analysis in the control group, and 179 in the intervention group. This is the table which shows baseline characteristics of participants, which is similar in both the groups, which included age group, sex, ethnicity, BMI, height, age that symptoms started, age at diagnosis. And SAVA reliever used in past 12 months, SAVA reliever used in past 4 weeks, at least one severe asthma attack in past 12 months, hospital admission due to asthma ever, history of atopic condition, ACQ-5 scores, on treatment FEV1 predicted value, median FEV1, median pheno machine use, and treatment allocation, household smoke exposure, which were similar in both the groups. Coming to outcomes, this is a table which shows primary outcome. This is the annualized rate of asthma attack, which is 0.23 in the intervention group and 0.41 in the control group, with a relative rate of 0.55, which indicates that there is 45% reduction in the asthma attack in the intervention group, which is again statistically significant. Regarding at least one asthma attack, there were 17% in the intervention group and 32% in the control group, with the odds ratio of 0.43, which indicates that around 57% lower odds of having at least one asthma attack in the intervention group was there, and it was again statistically significant. And time to first asthma attack was also higher in the intervention group, 329 days, and 295 in the control group, with a hazard ratio of 0.48, which indicates around 52% lower risk of having first asthma attack in the intervention group, which is also statistically significant. This table shows the severe asthma attacks. The annualized rate was 0.11 in intervention group and 0.18 in salbutamol group, with a relative rate of 0.60. This is not statistically significant, though there is some difference we can see numerically. Which shows around 40% lower severe asthma attack in the intervention group. In regarding at least one severe attack, there were 9% in the intervention group and 16% in the control group, with an odds ratio of 0.54, which is again not statistically significant. Regarding time to severe attack, was slightly higher in the intervention group. This is again not statistically significant. So this is a picture which shows annualized asthma attack rate, which I have already described. So this is a graphical representation. The blue one is showing the salbutamol group, and the red one showing the intervention group. The upper panel shows any asthma attack, and the lower panel shows severe asthma attack. In the upper panel, the asthma attack, which is clearly lower in the budesonide group as compared to salbutamol group, and in the lower panel, which shows severe asthma attack, the difference is not statistically significant, as we can see from the p-value. This is the table which shows assessment regarding asthma control and respiratory testing. In after all the visits, the proportion of participants in treatment step were compared. In those in step 1 in the intervention group were 87%, and in control group was 76%, which shows a clear difference. And those with and the odds ratio of those remaining in treatment step 1 versus other steps was 1.86, which indicates that there was around 86% higher odds of remaining in step 1 in the intervention group than in the control group, and this was statistically significant. Regarding ACQ-5 score, there were no difference in both the groups, and other parameters including FeNO, FEV1 percentage, growth velocity, and time off due to asthma, like days lost from school or days lost from work due to child care, were not different in the two groups. This is this is a forest plot which shows subgroup analysis was showing the treatment effect, difference of treatment effect in the groups due to different subgroups. The lower horizontal line shows overall effect and shows a relative rate of 0.55, indicates that around 45% reduction in asthma attacks in the budesonide formoterol group, and all the point estimates were mostly on the same side and favors budesonide formoterol group. But the difference noted in the subgroup analysis group were in the age group, sex, and FeNO, which shows that these parameters had greater effect on the treatment and which among the age group, adolescent age group 12 to 15 years favors treatment effect more compared to the lower age group, and the treatment effect in males is higher than in the females, and those having higher pheno levels responded more to the treatment with those with lower pheno values. The probable explanation to these could be like for age group, as the children adolescent age group, they are likely to use their inhaler on their own, and as soon as as soon as they are symptomatic, they can use their inhaler with better uh, technique compared to the lower age group, where the symptoms are has to be recognized by parents. Also, um, in higher age group, this is more of eosinophilic based inflammation, which again shows better improvement with the steroid group, steroid inhaler. And in the pheno group, again with a higher pheno, uh, also suggests more of type 2 inflammation, which responds more to inhaled steroids. But these were exploratory and cannot be used for conclusion because these subgroups were not adequately powered, but can be used as a base for subsequent studies. This is the
Dr. Nisha, you want a short break? It is fine with us. You don't seem to be well. If you wish to have a short break, have few sips of water.
Yes, sir. I'll just come back in a minute.
Yeah, please.
Thank you, sir.
Actually, yesterday she had fever and cold, and
Yeah,
she's the
we
only
can
team
sense
resident with
he
us actually.
probably herself needs maybe he is having dyspnea.
The the January session resident they are yet to join, so she is alone now. So suddenly she catched a cold and
No, we understand. She
yes.
just give her a short break.
Sorry, sir. I can start again. this this is a Kaplan-Meier survival analysis graph, which uh, shows the estimate of occurrence of asthma attack in a time to event analysis. So this is the x-axis shows time in number of days, and y-axis shows probability of uh, remaining as attack free, um probability of remaining attack free. So this is blue line shows of the blue line is of salbutamol group, and the red line is of budesonide formoterol group. We can see there is the distance between both the lines, which indicates that, and the budesonide formoterol group is higher than the salbutamol group, which indicates that in the intervention group, participants remained attack free for more number of days, and for more number of days, with a hazard ratio of 0.48, which again indicates that there was around 52% lower risk of getting asthma attacks in the intervention group. Also, this lower panel shows asthma attack, probability of asthma, severe asthma attack, and we can again see the difference is there in between the two lines, which shows that there was lower risk of severe asthma attack in the budesonide group with a hazard ratio of 0.55, but this was not statistically significant. Coming to another outcome they had mentioned was adverse event. So total of 162 adverse event with at least one adverse event was noted in the intervention group and 167 in the salbutamol group, but they were very rare. These adverse events were very rare due to treatment, which were treatment related. And regarding at least one serious adverse event, they were very few, 3% in the intervention group and 2% in the salbutamol group, but none were treatment related. So this was about the study, and so from this study, which compared salbutamol as only reliever in children 5 to 15 years, as needed budesonide formoterol reduced asthma attack by 45%, with which had a similar safety profile as compared to salbutamol group, and there was no growth suppression. From subgroup analysis, greater benefit was seen in older children between 12 to 15 years as compared to the lower age group, possibly due to independent inhaler use and early ICS delivery during worsening asthma. The strength of this study was that the MDI and spacer use was universal and it was child friendly. No dummy inhalers were used, and standardized dosing like 2 puff in each group were used. The limitation of this study was that this was an open label design and higher visit frequency was there than routine care with 5 follow visits in 52 weeks. And this was conducted during COVID-19 pandemic, which is not a real world scenario, but they had mentioned that this study was pragmatic, which we cannot say clearly because of the pandemic. And there was no dose counters, as they have mentioned. So inhaler use patterns were unknown, but as far as we have searched, the Symbicort in Rapiheller which they had used comes with a dose counter, but we are not sure whether they had received that dose no dose counter Symbicort from the company itself. And this study has various clinical implications as it supports GINA and Lancet Asthma Commission. So now evidence extends to children more than 5 years. And budesonide formoterol can prevent attacks. It's safe and no effect on growth. And it shifts practice away from SABA only therapy, which has a potential to increase exacerbation. So they concluded that as needed budesonide formoterol is superior to as needed salbutamol in preventing asthma attacks in children with mild asthma with a similar safety profile. Coming to critical appraisal of the study. Did the study address a clearly focused research question? Yes, I mentioned about the PICO format. Was the assignment of participants to intervention randomized? Yes, randomization was by stratified balanced block randomization, where all participants who entered the study accounted for its conclusion. Yes, we could see from the consult flow whether participant blind to the intervention they were given. No, this was an open level study. Whether study group similar at the start of randomized control trial. Yes, the baseline variables were similar in both the groups. Apart from the experimental intervention, did each study receive the same level of care? Yes, both the treatment, both the groups received same treatment, same level of care. Were the effects of intervention reported comprehensively? Yes, they were reported comprehensively. And was the precision of the estimate intervention or treatment effect reported? Yes. And do the benefits of experimental intervention outweigh the harms and costs? We can't tell about this because in the protocol and the article they have mentioned that baseline cost effectiveness analysis will be undertaken, but nowhere they have nowhere in the end cost effective analysis have been mentioned, neither in the supplementary article or the protocol or the article itself. Can the result be applied to your local population in your context? Yes, it can be applied. And would experimental intervention provide greater value to the people in your care than any of the existing interventions? Yes. The GINA guideline supports using anti-inflammatory reliever therapy among children more than 12 years in step 1 itself. So it can be studied and used in children below that age group. Thank you. Thank you for your time.
Thank you, Dr. Nisa. Really, you are unwell, but you complete this presentation. Thank you for that. So now I invite Dr. Joseph, sir, to take carry forward session, sir.
Okay, thank you, Dr. Ajay. So if anybody has questions needing clarification, they can type that in the chat box and we will try to answer it as we go along. Just a couple of questions.
Can we unshare this screen for the time being?
Yes, sir.
Yeah, this is better. Yeah.
Wonderful. Dr. Nisha, just a couple of questions.
Yes.
So did their treatment protocols mention that as needed SABA, when a child required it, for how many days they were supposed to take it? I could not locate that anywhere actually.
Yes, sir. They did not mention
They did
about.
not mention it at all. All right.
Yeah, I was also wondering, it's okay that because the objective of short objective as and when needed SABA or any therapy is symptom control, and recently it's also about preventing further attacks, which already GINA guidelines have accommodated for older children. But also, it means I could not find in the study. What happened to their how many times in each group they needed to use the as and when required doses, and it is also surprising to find that the dose counter on the inhalers could have easily provided data on that. So such a rigorous trial could not provide the provision for dose counters on the inhaler, because you also need to compare how many times did they have to use the reliever therapy in each group, because it is possible that in one group maybe the attacks prevention of moderate to severe attacks is less, but the milder symptoms are continuing, and because the milder symptoms are continuing more in one group, say formoterol group, so that group actually becomes if the dosing of initial reliever therapy is too frequent, it is acting as a prophylactic for preventing future attacks. So unless we provide information about whether the number of doses in each group was similar uh, or not, so I'm not sure why that data was not provided. I could not see that data. Could you find it? And maybe they have published other papers out of it, but they are mainly about protocol. So I'm not means I do not know. I doubt that this data would be provided in those papers as well. Could you comment on that, Dr. Nisha? Is it like what could be the reason of that not even included as an neither as a outcome nor as baseline characteristic?
No, sir, they had not included regarding the dose or specific intervention and the control group, how much they would have, because those counter was not there as they have mentioned. But we, as per my review, like the Symbicort Repealer they were using comes with a dose counter. I have shown in the image also.
Otherwise, also means even if it doesn't come with a dose counter, they could have just asked the parents to record the number of doses used during or number of times the inhalers were needed uh, during the study period, which was pretty long, 52 weeks. Anyway, I think the presentation was excellent, and you have read the article thoroughly. But we also expect you to find out much more beyond what they have reported as limitations and other things. One thing about the methodology, they have reported the allocation concealment was by a secure database. Can you elaborate on this? What is secure database allocation concealment?
So that could be probably a computer-based allocation, like we use, which we use normally is the snooze, which is the uh, envelope allocation concealment. That could be probably the computer-based allocation concealment, which uh, which was secured.
Okay, so secure data based concealment is it's actually a centralized process where it's kind of a centralized randomization where there would be a central place or a center where all the randomization codes are there with them, and it's a real-time allocation. So whenever they're especially used in the multicentric trials, because this trial had 15 sites. So it is very useful for multicentric trials where if any eligible participant is there, then the central coding system allocates. So this could be this is usually web-based allocation where it could be automated voice recorder, or it could be a telephone consultation. But this is perfect. Means this is better than snows, especially for the multicentric trials like this. But here they have written that the block size varied by site. So this is something confusing. Means in a central randomization, there is a combined randomization across all sites. Because if you see 15 sites contributed, say about 340 participants, so it means that every site contributed to only about 20 to 22 participants. And it's not possible to have individual randomization sequence for each site, and that is concealed and at a central place. That would be quite complicated kind of randomization. So I'm not sure whether this statement that this block size varied
Right, right.
in each site is a error, or they did actually individual randomization at each site and all the codes were concealed, and at the time of enrollment, besides the enrollment number, the site also has to tell about the name of the site and that code was generated. So this 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 thing is unclear to me. Dr. Joseph, can you uh, further?
So my personal feeling is when I look at not only this issue, there is another interesting issue which I will try to link with the two. So one of their exclusion criteria reads as follows: hospitalization for 24 hours or more due to asthma in the past 12 months. This is an exclusion criteria.
Yes,
In the very next paragraph, where they're talking of stratified randomization, they say that stratification was by age group, okay. A
severe.
history of a severe asthma attack in the previous 12 months. So they have stratified by people who had zero asthma attacks in the past 12 months and also by those who had more than or equal to one.
Yes.
You can't have more than equal to one because that was an exclusion criteria.
Yes, sir.
The hospitalization as well as the life-threatening episode was the exclusion criteria, not the severe attack. So it is
Mm.
It's
possible that
hospitalization for more than 24 hours due to asthma in the
yes.
past 12
So
months.
it is possible. Is it possible? Means as respiratory people, maybe policies in the New Zealand Is it possible to have a severe attack and not requiring hospitalization for more than 24 hours? That is possible, I think. If
Mm.
a person gets, because I also got through, not in only in this, but I also got when they presented the results about severe attacks, because there also it was confusing. But when I read in depth, I interpreted that it is possible, because it is again about hospitalization for 24 hours or more due to asthma in past 12 months, or previous life threatening, not severe, previous life threatening asthma requiring ICU. So it is
That
possible
is
that these children had severe episodes which did not require hospitalization for 24 hours or more, and neither require ICU care. So that seems to be the case in this.
ICU care is, of course, in a different point altogether. It is this hospitalization thing which is sounding a bit funny. Anyway, but it's difficult to make out since we don't have access and we have not read their protocol. But couple of things like that, appeared as a little odd thing. The other thing, for example, is when we look at their data on adverse events, or is it some other one, wherein the numbers suddenly become 167. Did you see that, Dr. Nisha?
Yes, sir.
There's some data, and is there no explanation for it? No.
So they have given explanation regarding that as more of respiratory infections. They mention all the adverse events in the list.
No,
That
not that. When the denominator has changed to 167 in both the groups. You presented that up there on the thing.
No, that is at least one adverse event in 162 uh, in
That
the
is
intervention
160.
group and 167 in the control group. Any adverse, at least one adverse event.
uh,
Some place the denominator changed. No, no. Okay, it doesn't matter then. Maybe I'm making a mistake. And one more thing, did you see that the time which it has taken for a child to go and develop an exacerbation is almost 11 months or 10 and a half months. So a really, really long time. Hmm? So when
Ah,
that happens,
yeah, I also noted this. Dr. Neha, Nisha, sorry, can you explain this? Because when I read at the definition, this was one of the my point also. Because if you see this data, just read this data, it appears very odd. It means the first episode is occurring almost at the end of the year. So I took some time to understand. Means how is it possible that? So then I noted that they have included, because if you see their data, most of the patients in each group, they did not have any single episode.
yes, sir.
So when they analyze this, because if you see this time to event, it has been calculated as either the time to the first episode in those who had the episode, or the last day if they did not have any episode. So that is affecting this data. So in my interpretation, if I had to do this analysis, I would have included only those children for this analysis who had at least one episode, so that you can actually calculate the real time to event. Here, what is happening is, because most of the patients in each group, they are not having any, so they are contributing 365, 365, 365 to this data. That is making it 325, and it's very odd to understand unless you read it in the detail. What is why it is like this? So I would have analyzed it in only for those who had at least one episode. That would have made it less confusing. So I'm not sure why did they include all the participants to provide this time to event the first episode, the number of days data.
yeah. And sir has given you the answer, which we were kind of thinking you will work out. But that is the answer to this point. That is why you see the time to the first episode is very large. Actually, in a trial like this, once a child has developed an episode, then there is already treatment failure. So if they
Yes.
count treatment failure as that, then the problem becomes little less. The other odd thing is they have talked of everything in terms of episodes and all, but not told us the number of children who develop these episodes. That is usually an important outcome, because if they have one or two poorly controlled children each side who keep on having these episodes, the same child will contribute to a number of episodes and they will all get counted as events.
Yes, sir.
Whereas if it is multiple children having fewer episodes, that will also not be counted separately. So
Yes.
this is one funny thing which they have done over here by not telling us the number of children. Other than that, this trial looks very robust and everything. The CASP checklist is a rather simple to use tool for critical appraisal, but you must remember that CASP's main focus is mostly on whether we can apply the results or not, based on some methodological things. Nowadays, we have moved on to other tools for RCTs. This is just for you to remember. Do you have any questions for the for Dr. Dheeraj or myself or anybody, Dr. Nisha? Meanwhile, we'll track the chat and see if there is something we can reply.
Yes.
Yeah, which Dr. Ranjan has put a point that I was also wondering the Poisson regression and means the reason why did they do such a complex analysis rather than simply calculating the number of events, the mean differences and relative risk is probably this only because they have somewhere accounted for the number of events when they are doing because they have analyzed everything as per the linear regression analysis. So I think one of the reasons could be that because the events are already occurring in between and also they are using the rescue therapy, they are upgrading to step 2, but they are finally including all the children irrespective of whether they required upgrades or not. So somewhere they are using this complex regression linear analysis to account for these events which happened in between. That's what I also think. Acha,
Can
Dr.
I,
Nisha, can
sir,
you
can
tell
I?
me why because it's a randomized controlled trial. If we see their table where they have reported outcomes, somewhere they are reporting odds ratio and somewhere they are reporting relative risk. So I'm not sure. Could you find any reason why odds ratio has been reported for asthma attack count? Why odds ratio has been used for a number of severe attacks? Why odds ratio has been used for treatment stepping up? Whereas for the main outcome of annualized rate, it relative risk.
It is relative rate they have mentioned.
No, odds ratio. I'm saying any reason for presenting the data in terms of odds ratio for many outcome? When it's a randomized control trial, which is a obviously a prospective and longitudinal nature of study, why did they have to report odds ratio and not relative risk for all those outcomes? I don't know. Means I could not find any reason. If you can clarify, you could understand.
So I'm not sure of this, but I'm not sure.
Yeah, you are right. But why odds ratio has been used for binary outcomes and not relative risk?
Yeah, the authors have not given any explanation. It's a bit curious about that. In fact, if we look at their figure 2, where they have shown us the confidence intervals, up till now they were only talking about the point estimate of 0.23 episodes per child per year versus 0.41. Even though the difference looks statistically significant, there is actually an overlap of the two confidence intervals, which makes it curious how it became a statistically significant result. That's one thing. The second is for each of their subgroup analysis, you will see that one subgroup seems to benefit, the other subgroup has no benefit at all. And the entire cumulative result is being driven then by that subgroup wherever the benefit is seen. So these are all very curious things in this particular trial, which they have not given much explanation about in their discussion section and things like that. But other than that, it is a very well designed, well conducted, and all that. So there are some messages that we can take from this. But again, like we always say, when we choose to apply or not apply the results of a trial in our own setting, we must make sure about the differences in the children, the intervention, and the various other things which go into the healthcare system kind of a profile before we look at that. So while it is easy to say, yes, we can also use, instead of as needed salbutamol, we can also switch to the combination. We must make sure that the rest of the things are also matching. Otherwise, you get a funny situation in which on paper, in theory, it looks like we can use those same findings, but in real world, we may not get the same results as in a trial setting. We must remember that.
Yes.
So, Dr. Nisha, any reason you said that in the checklist you said that the results are applicable to our setting? Any reason you chose to state that? Because if I see their subgroup analysis, I would differ.
So the genetics and environmental exposure could vary, but we can conduct a similar study and
No, conducting a similar study is other issue with because applicability of this study to our setting, that is what that checklist mentioned. Because if you see the subgroup analysis, you see first of all you see the ethnicity Asians in the mainly benefit is seen in the Europeans. And then if you see the exposure to smoke, again, it's the benefit in this one subgroup, as Dr. Joseph stated, which is a bit usually if the effect is to be because of like the sample size is reducing, then it should have been no effect in all the subgroups, but the pooled effect shows net positive gain. But here, yes, it's a bit odd that one subgroup in each is driving the total outcome. If you see that exposure to smoke never is leading to benefit wherever there is an exposure to smoke, the subgroup shows less benefit or no benefit. So in India, the etiology of asthma, the triggers, uh, smoke exposure, ethnicity, all would be different. So I would say at least can't tell, not yes, whether these results can be used in our setting unless they are replicated in our setting because the triggers for asthma could be different. The inflammation uh, during in the mild asthma, uh, inflammation as a trigger could be different. And again, the viral infections, I could not see how many of these episodes were triggered by viral infections because fever data is also missing in the. I could not find at least the children who had febrile episodes whenever they required, say, 3 or more days use of. Because sometimes these therapies do not work when there is a infection triggered kind of asthma or maybe wheezing as a part of infection and it's not a not because of endogenous atopy. It's not infection triggered wheeze, but it is infection causing airway inflammation and causing an actual mild obstruction to the airways. So in India, maybe the viral respiratory infections could be a driver of wheezes rather than just endogenous atopy. So there could be reasons for differences. So unless the results are, what do the current GINA guidelines for this age group say about mild asthma, or you said infrequent asthma? What do they advocate for older children? You said, or and the paper also said they advocate the anti-inflammatory reliever therapy. But what
yes.
about younger children? Is it still SABA only, or is it
So
something else?
for children between 6 to 11 years, it is recommended that whenever reliever SAVA is taken, uh, ICS, low dose
So they
ICS.
have already advocated ICS based on what evidence? Based on because they claim that this is the first paper. So based on what it's just extrapolation from the data from adults. They have GINA has given the guidelines of use of ICS for infrequent asthma as well.
There is this assess study from which it was a study in children, which was not about ICS formoterol, but regarding use of ICS as a reliever therapy in children between um 6 to 17 years of age, was showing benefit in the ICS reliever group compared to the only maintenance group also. So they had considered adding anti-inflammatory reliever therapy in this age group also.
Okay, so there is some observational data. Regarding the adverse effect profile also, if you see the growth in two groups, although it's only a 1 year study, but if you see the growth, there is a negative growth velocity in the intervention group, in which is just reaching the borderline significance. So that is also maybe a issue for concern, especially if the treatment needs to be continued for uh, many times. Because the reason we do not use steroids in mild asthma is that because they do well otherwise as well. So we do not want them to get say exposed to the adverse effects of steroids, especially growth. So that also needs to be seen besides the cost you already mentioned before we say that this kind of treatment should be used for all children with the infrequent asthma.
So, but they have shown that that was not statistically significant. So we could probably consider that the growth velocity was similar in both the groups they have shown.
Yeah. And do you know why that is, Dr. Nisha?
That could be probably because of the treatment protocol that
Exactly.
they had escalated in the control group also using steroid in both the groups in step 2 and 3.
No, because most of the children never required any escalation. So they would have taken a few days of as needed ICS LABA or SABA. And naturally, that steroid is not enough to affect their growth. So the other important thing to remember is there is a big cultural difference, besides all the points that we have discussed, between their setting and ours. So all these European and American and all these people, they use SABA very liberally. In fact, so liberally that people who should not be on large doses of SABA or for prolonged periods of time end up getting it. And then there have been mortalities because of that. So all their struggle to get away from SABA is related to that. Whereas in our own context, if there was a child, maybe even an adult, who required SABA so frequently, most physicians would have put that person on inhaled corticosteroids. But it is some peculiar thing that people in the West, they self-medicate themselves with SABA and all that also. And all this stuff towards moving to ICS LABA, initially it was for adults, then it became 12 years and older, then it became 6 years and older. Now we are struggling very hard to bring it down to 2 to 5 years, is actually related to this complication with SABA. Obviously, if any medication is used more than it should be taken, or for longer duration than recommended, or in much more frequency than recommended, there will be adverse events because of that. So our population has so far not shown that propensity to keep taking SABA to that extent. That is why, exactly as sir also said, we can't just extrapolate the findings of a trial and plug it into the healthcare system that we work in our country. But discussion is good. We have had that point. Dr. Rashmi, would you like to make? I'm filling in for Dr. Indu. So we have done Dr. Dheeraj and myself, we have done a lot of talking. Would you
Yes.
like to make some, concluding remarks, because it's already an hour and 12 minutes?
Yes, sir. Very pertinent and kind of brainstorming session. And every point I think was discussed. And the trial, actually, the 15 sites were kind of different. I think some in the periphery, some in the center. So the treatment of like the treating doctor, they varied actually. So it was up to the kind of control of the treating physician to kind of give some rescue treatment or decide it. And though they told that the protocol has to be followed. And the same thing happened in the randomization as I was telling. So it was variable. So again, as per the site, actually, I think for more flexibility, they allowed this. Usually, it doesn't happen. You cannot have different codes. Then you have to have separate codes for separate sites. So probably they have divided it into two types. They have mentioned, and they have used the block size of 2 and 4 in for one and 4 for other. So for some flexibility, maybe they have used, and there are some problems like we are also discussing. So something was not clear, and then. Regarding this applicability, yes, we can tell whether it can be applied, but it has the potential for application because Jina is pushing, and in future we'll have AIR in, I think, on children less than 12 years. So this trial has given a kind of insight that there is a potential role of this AIR in children less than 12 or so, though there was some kind of subgroup difference, and they pull. This was kind of a post hoc analysis. Like they told that probably the older children they can use it in a better way, and they can perceive the symptom better. So there was a kind of tendency towards more significant result in that, but we don't know why there was a difference. Like it was not showing significant difference in 5 to 11 years. And another confounding factor was that it was conducted during COVID time, during lockdown time. So that probably, I think, the major factor that affect regarding the exacerbation, including mild and moderate, because this will happen erratically. Okay, so that may have a major effect. They have also told the same thing. Like there was a larger gap between the onset of the first exacerbation. So there are so many things they have kind of they have described, and it was not in their control because the trial started at a time when the this lockdown everything happened. So there is a lot of variability, everything, but this trial shows kind of that the results show that okay, it has the applicability, but as Dr. Saurav was mentioning that we should have the trial in our setting, in our population before of our conclusion can be made. So very good study, but every study will have some loophole because you are conducting the community. Everything is not under your control. So some kind of things will happen, but it was a good discussion. Thank you, sir.
Thank you, Dr. Rashmi. So, Dr. Ajay, would you like to give the vote of thanks, to our expert, everyone?
Sir, before that, sir, Dr. Rawat, sir, if you want to say something, sir. Okay, sir, Joshi, sir, if any comments, sir, from your side. Sir, please unmute, sir.
Thank you very much. Actually, I missed the main part of the result because I had to join another Zoom meeting for a brief time. But I was more curious to know about how to extrapolate the results of this particular study to our children. We have been actually following GINA guidelines, and I think that has brought a lot of clarity in our mind as regards the use of anti-inflammatory relievers. Now, whether or not, because I think the study which is being done here in this probably involves fluticasone, which we do not really use very frequently. But again, does it really apply to our context? All probably this study gives us a little insight saying that what GINA has been advocating, that you should not be using salbutamol alone beyond the age of 6 years as a reliever only, because you have to substantiate with a inhaled corticosteroids along with that, because there is always a risk of exacerbation. And I think with stalwarts like Dr. Matthews sir and Dr. Dheeraj, I think most of the statistical language which was used here was slightly difficult for me to understand. But nevertheless, I think the crux of the matter is, from a clinician's point of view, how would it be extrapolated to our society? And that is my query to both these stalwarts, Dr. Dheeraj sir and Dr. Joseph sir. What would you draw the conclusion from this particular trial? Dheeraj bhai?
Yeah, I think the conclusion is because there has already been evidence from older ages in two trials which he mentioned, and this trial adds to the existing body of evidence and extends the potential benefit of anti-inflammatory reliever therapy to the younger age group as well. So I don't see any reason if it works in older children why it should not work. And it may not work equally well, or it may work better, but there is no reason that it will not work at all. So definitely there is a role of this kind of treatment, but before we apply it in our setting, we need, because our asthma could be different, our triggers could be different, and the subgroup analysis shows somehow that it didn't work as well in Asians and those who had exposure to smoke, these settings which we have in our country. So we need to have the when the study conducted in our setting before we can just use it, but definitely it has the potential. But then that cost is another issue because the number of doses required for inflammatory just a SABA versus could be large. So the cost presently could be prohibitive if we used it in say community settings in low resource settings, you say, which beyond private healthcare providers. Uh, Funding for this study I could not find because somewhere they have written that funders had no role in the concept design, but I could not find the funding being declared because the both products, the this thing they have mentioned all the products being used from one particular firm, which is GSK. But whether GSK had any role in funding, it's not clear, at least in this part. But they have probably published another protocol where it may be clear. So definitely, this treatment has the potential. And there is evidence from the older age groups. So definitely, we should conduct Dr. Joseph and other expert. They need to generate evidence of its efficacy or otherwise from our settings, and definitely it has the potential to be. And you already said that Gina says that apart from SABA, you also used ICS, although they say separately. Now, this is about not about SABA, this is about LABA and in combination with steroid. So, this needs to be evaluated in our country before we adopt it based on this particular study.
So this
Thank you.
formatrily actually fast acting beta agonist.
Okay.
So
Yeah.
So, may I conclude, sir? Vote of
Yeah,
thanks.
please.
Uh,
Yeah.
so, my sincere thanks to Dr. Nisa for her nice and elaborate presentation in spite of her ill health. So, please take care of her health now. And I also thanks to session mentor, Dr. Rasmi Ranjan Das, for this nice article, choosing nice article. I also thanks to Dr. Dheeraj sir for giving your valuable time and participating in this discussion. And we are very much grateful to you for this. And I also thank Dr. Joseph sir for as well, sir. You are always giving nice. Putting your views, and thus we are benefiting from your experience. And I also welcome our past press chairperson, sir, Dr. Rawat, sir, for attending this session. And finally, I also giving thanks to sir, Dr. Joan Joshi, sir, for attending this session and present throughout the session, sir. So I also thanks Bafna, sir, and our EB member, Kasi Bhandaru, ex-EB member, and other participants. So finally, sir, now I am concluding the session. I will meet again in the next month on the 18th of the Feb with the new article from the new institute at the 9 p.m. Till then, thank you all of you, sir. Good night. Subhratri, sir.
good night all.
Thank you. Good night.
Thank
Good
you.
night.
Thank
Thank
you.
you.
Good night.
Take care,
Thank you,
Dr.
sir.
Bye.
Nisa.
Thank
Bye.
you.
Good night, sir. Good
Bye.
night, sir.
Good night.
Yes.